This conference will now be recorded.
Hi everybody. I'm sorry, కొంచెం late అయిపోయింది. So today your class is on ChorioCarcnoma. Okay. So as all of you know, ChorioCarcnoma usually follows a vesicular mole. It falls into the group of gestational trophoblastic neoplasms. Okay. ChorioCarcnoma, placental site trophoblastic tumor, all those things, they come under gestational trophoblastic neoplasm, out of which ChorioCarcnoma is most important. Okay. So ChorioCarcnoma is actually subdivided into three varieties. Gestational ChorioCarcnoma, which is more common, that is, it follows a vesicular. Non-gestational ChorioCarcnoma is where it follows a germ cell tumor of the ovaries. Then unclassified, where it neither follows a gestational nor it follows germ cell tumors. Unclassified ChorioCarcnoma. So out of all these three, the most important is gestational ChorioCarcnoma following a vesicular mole. Okay. So gestational ChorioCarcnoma, as the name itself is suggesting, it is related to pregnancy. So this is again divided into uterine, extrauterine ChorioCarcinomas, out of which uterine ChorioCarcnoma is most common. So it develops in the uterus following a vesicular mole, or following a miscarriage, or following a normal delivery. Okay. And very rarely ChorioCarcnoma along with an intact pregnancy has also been reported. But as far as you are concerned, it is important to remember that it usually follows a hydatiform mole, more than 50% of the cases, and following miscarriage and a normal delivery. Okay. So extrauterine is again something like an ectopic pregnancy. So wherever there is a site of ectopic pregnancy, extrauterine ChorioCarcnoma can also be present, where you don't find any tumor in the uterus, but the mass will be growing at the ectopic site. Then intraplacental ChorioCarcnoma, very rarely it is found in the placenta associated with a viable pregnancies. So this is very, very rare. For all practical purposes, it is important for you to remember that uterine ChorioCarcnoma is most common. The non-gestational ChorioCarcnoma, that means it is not related to the pregnancy. It is divided into two categories. One is it is derived from as a germ cell tumor. So it originates from the subtype of a germ cell tumor which develops in the ovary, either before marriage or in adult males, in girls or in males. This is supposed to be more resistant to chemotherapy than a gestational tumors. Then gestational carcinomas derive from other carcinomas, that is choriocarcinomatous changes of other carcinomas, which is also again very rare. Then unclassified, which neither belongs to any of these categories. So gestational choriocarcinoma, this is a malignant neoplasm which is composed of atypical trophoblast. And the more characteristic feature is absence of chorionic villi. So this is the most important histological feature which will differentiate from invasive moles. Invasive choriocarcinoma, where it is locally malignant. Whereas in choriocarcinoma, there are only sheets of trophoblast, atypical trophoblast, without any tendency to form the chorionic villi. That is a characteristic histological feature of gestational choriocarcinoma. Then, as we have already noted, that they usually occur subsequent to molar pregnancy, that is hydatiform mole or vesicular mole in more than 50% of the cases, following a miscarriage in 25% of the cases, normal term pregnancies, term deliveries in around 22.5% cases, rarely ectopic pregnancies in around 2.5% pregnancies. So mostly it follows a vesicular mole or hydatiform mole. So that's the reason why we need to do a follow-up of vesicular mole. Post-molar surveillance has to be done for 2 years, because the time of origin of choriocarcinoma is mostly within 2 years. It can occur at any time, but most commonly within 2 years. That's the reason why all full vesicular mole or hydatiform mole cases have to be followed up at least for 1 year. The contraception has to be used. Okay. Then morphologically, it is naked eye appearance is soft, fleshy, yellowish, white or purplish tumor with a marked tendency to form large areas of necrosis, hemorrhage, focal softening, hemorrhage, and so on. So this is the naked eye appearance of a ChorioCarcnoma inside the uterus. Can you see? So it is red, the hemorrhagic areas of necrosis will be there. Violet in appearance, yellowish in appearance, and so on. That's it, naked eye appearance. Then the histopathology is classically described as bilaminar, dimorphic, or biphasic. So you find alternating trophoblastic cells and the sensational trophoblastic cells without any formation of villi. So intermediate trophoblast may show marked variation in the degree of cytological atypia. Just like any other malignant cells, these cells also show atypical features. Vascular invasion is very prominent. Chorionic villi are not a component of choriocarcinoma. That is what differentiates choriocarcinoma from an invasive mole. And it lacks the intrinsic endothelium-lined vascular channels in the center of the tumor, making it a unique malignant solid tumor. So this is a gross appearance of the hysterectomy specimen showing the choriocarcinoma growth, and then the histological pattern. So you can just see sheets of trophoblastic cells showing all malignant appearances like enlarged chromatin, abnormal mitotic figures, all those things. But there is no attempt for villus formation at anywhere, right? So this is a gross and histological appearance of a carcinoma. Then how is it spreading and how is it staged? So spreading, as in any other carcinomas, direct spread can occur into the surrounding structures, that is parametrium, tubes, and ovaries. The blood spread is occurs very early to the distant organs, particularly the lungs, brain, liver, and other ones. And the commonest sites for metastasis are the lungs in 80% of the cases, vagina in 30%. So vaginal metastasis, always you have to remember that most of them are suburethral nodules which are present in the lower 1/3 of the vagina, and they are not direct spread. They are retrograde venous or lymphatic spreads. Okay, very vascular, they bleed on touch. Sometimes the patients just bleed to death from these suburethral nodules. So lungs most common 80%, followed by vagina 30%, then brain and liver 10 and 10%. So the distinguishing feature of choriocarcinoma is that though it is a carcinoma, it spreads mostly by blood, just like a sarcoma. So that's the reason why metastasis will appear very, very early in these cases, particularly the lungs and the vagina, and in late cases in brain and liver. So spread is very early because of the blood spread. So this is a Figo's staging, anatomical staging. Stage 1 is where it is confined to the uterus, just like any other staging in any other carcinoma. Stage 1 is always confined to the organ. Stage 4 is always a distant spread. So only 2 and 3 you have to remember. 2 is always intrapelvic, 3 is always extrapelvic in genital cancers, right? So if you remember it that way, it becomes easy to remember any staging for that matter. 1 is always confined to organ, 4 is always distant spread. 2 is inside the pelvis, 3 is outside the pelvis, that is in the abdomen. So 1 is confined to the uterus, 2 is extends outside the uterus, but is limited to the genital structures like adnexa, vagina, broad ligament, and other ones. Stage 3 is extending into the lungs with or without the genital tract involvement, that is blood spread. And stage 4 is mets to other organs, that is brain, liver, kidneys, ovaries, gastrointestinal tract, and so on. So this is Figo's anatomical classification, staging, anatomical staging of choriocarcinoma. So you have another modified WHO risk scoring system. This was modified in 2000. So these risk factors are given a score of 0, 1, 2, and 4, right? So you have 1, 2, 3, 4, 5, 6, 7, 8. You have 8 factors. So one is age, less than 40, more than 40, 0 and 1. Antecedent pregnancy, if it is mole, it is 0. If it is miscarriage, 1. It's a term pregnancy, it becomes 2. That means if the choriocarcinoma is following a normal delivery or a term pregnancy, it's a high risk. Then interval between the pregnancy and the appearance of the carcinoma is 4 months, 4 to 6 months, 7 to 12 months, more than 12 months. So if the longer the time taken for the appearance of the choriocarcinoma, the higher is the risk. It is because when we are following up of these cases of vesicular mole, particularly up to 2 years, it's easy to recognize if the woman is developing malignancy. But after some time, let us say after 1 year, 12 months, 1 year, 2 years, it becomes difficult to correlate this carcinoma to that of the pregnancy unless you are aware of it. So always you should be aware of the fact that choriocarcinoma can follow a normal delivery, right? So unless you are aware of this fact, it becomes very difficult to diagnose. That's the reason why it is placed in a high scoring. More than 12 months, the risk is 4. Then pre-treatment serum HCG values less than 10 to the power of 3, between 3 and 4, 4 and 5, more than 5. So HCG values are related to the tumor volume. You know that. Then the tumor size, less than 3 centimeters, 3 to 4, more than 5 centimeters. Then site, number of metastasis. So lungs, low score, spleen and kidney 1, gastrointestinal tract 2, brain and liver becomes 4. Right? Then number of metastasis 0, 1 to 4, 5 to 8, more than 8. Then previously failed chemotherapy. Supposing you are following up a case of vesicular mole and you should see that there is a persistent GTD is there and put them on single drug chemotherapy, but then the patient do not respond, then the score becomes higher. So prior failed chemotherapy, if it is single drug, the score is 2. If it is more than 2 drugs, then it is 2 or more drugs, it will be the 4. So this is a WHO's risk scoring system. Depending on these, just remember this risk factor, that is enough. If the score is 6 or less, it is a low risk group where you can treat them by a single agent chemotherapy. Whereas 7 or more, it is high risk where the woman needs combination chemotherapy. And the best part of this carcinoma, choriocarcinoma, is that it is the cure rates are very, very high, as high as 90 to 100%, particularly in the low risk group. And the tumor is chemosensitive. And the cure rates are very, very high if they are properly detected in the early stages. So that's one malignancy in the females, which has got a very, very high cure rates compared to cervical cancer or ovarian cancers, where the 5-year survival rates are very low, particularly in advanced cases. So this tumor particularly has got a very, very good prognosis compared to the other cancers. So this has combined both, that is anatomical staging as well as risk scoring. So actually in staging again, substaging is also there, like ABC. A means there are no risk factors, B means there are 1 or more risk factors, C means 2 or more risk factors. But the substaging has been removed in the recent classifications. Right? So just remember the anatomical staging and the risk scoring of choriocarcinoma, right? All these 8 points for risk scoring. So this is WHO and FIGO's modification of anatomical staging and risk scoring, right? So what are clinical features? So now that we know that it is following, we have gestational, non-gestational, unclassified, uterine, extrauterine. So you just say a choriocarcinoma, it always means an uterine choriocarcinoma, and then it is usually following gestation. So gestation, it usually follows vesicular mole in more than 50% and 25% miscarriage and 20% a normal delivery. normal full-term gestation, whether delivery, vaginal or cesarean. And less than 5% follow an ectopic pregnancy. Right? Then we have staged it, anatomical staging and risk. Right? Then pathology, gross and microscopy. So for that we have learned. So what are the clinical features? How do these patients present? So persistent or irregular vaginal bleeding is a commonest symptom occurring either after a normal labor or a cesarean, any delivery, after miscarriage or after the evacuation of a vesicular mole. The patient complains of continuous or irregular bleeding. So bleeding can occur within days or months, but rarely after 2 years. So most of the carcinomas, the time of onset is usually within 2 years. Very rarely they appear after 2 years. That's the reason why diagnosis becomes difficult and the scoring is also high if the time onset is more than 2 years after the antecedent gestation. So that is number one, persistent or irregular vaginal bleeding. The second symptom is a vaginal discharge. It may be blood-stained and offensive because of ulceration and infection. You have seen the growth, how big it is. So such a big growth, a hemorrhage, and then there may be infection. So the patient may have blood-stained, purulent vaginal discharge because of ulceration and growth. Then third one is amenorrhea may be present because the tumor is secreting continuously HCG. So because of that continuous HCG, the patient may complain of lack of menstruation. And pelvic pain and pressure, if there is an enlarged uterus or where there are ovarian cysts are present, the patient may even complain of pelvic pain or pelvic pressure. So these are the most common complaints, that is continuous or irregular bleeding per vaginum following a delivery, miscarriage, or evacuation of vesicular mole. Offensive blood-stained discharge. And third one is amenorrhea because of high levels of HCG, and pelvic pain or pelvic pressure because of enlarged uterus, enlarged ovarian cysts. Right? So these are the four most common symptoms with which the patient can present to us. Sometimes the patient can present to us with features of metastasis, like a most common site of mets being lungs. They may complain of shortness of breath, cough, chest pain, hemoptysis. So they may come with only lung mets. Then sometimes they may even have, if vaginal metastasis is present, irregular and very brisk hemorrhage, right, in vaginal mets. Then neurological symptoms, if there are brain mets, hemiplegia, convulsions, headache, dizziness, visual disturbances, suggestive of brain mets. Then epigastric pain, jaundice, vomitings, intestinal obstruction, and so on in case of liver and gastrointestinal. Right. So rapid growth, widespread dissemination because of its nature of spread, that is to blood spread, and a high propensity for hemorrhage makes this tumor a medical emergency. So the patient may come with severe hemoptysis, severe bleeding per vaginum from the vaginal mets, or intraperitoneal hemorrhage and so on. So they may come as an emergency to the casualty. Then vaginal mets, the uterus may be enlarged and boggy. They appear as bluish red vascular tumors, bleeding easily on touch. Then thecal lutein cyst may also be palpable because of increased HCG. Right? So metastasis to the lower genital tract, they present as purple to blue and black papules or nodules, which are extremely vascular. And if you try to do a biopsy, they bleed profusely to death. It's very, very difficult to control bleeding from these metastases. So you are never supposed to do a biopsy of these vaginal nodules. So these are the suburethral nodules to the lower genital tract. So they appear bluish, and if you try to biopsy them, they bleed profusely, and the patient may even bleed to death. So we have seen patients coming with severe bleeding per vaginum, and you think it is a case of a carcinoma or something, and try to take a biopsy, and they bleed profusely to death. Then those are the symptoms. Then the signs. So on examination, you find abdominal tenderness may be present. If there is liver mets or gastrointestinal metastasis, hepatomegaly, splenomegaly, abdominal distension, ascites, and so on. Abdominal guarding and rebound tenderness may be present if there is a hemoperitoneum because of bleeding from an abdominal metastasis. So signs of hemoperitoneum may be there. Then bleeding from a metastasis may result in signs and symptoms of a hemorrhagic shock. The patient may present with signs and symptoms of hemorrhagic shock. Then, so there is no need for a histopathology. So this is very paradoxical. Like, any other carcinoma in the body, any other malignancy in the body, elsewhere in the body requires histological confirmation to start any treatment. But this is one peculiar malignancy, that is ChorioCarcnoma, where you don't need a biopsy. The treatment can be, the condition can be suspected and treatment can be started based on the hormonal assays. So serum beta HCG is elevated in the absence of a pregnancy. It always indicates a trophoblastic neoplasm, right? So this is one malignancy in the body which don't require histological diagnosis. You are not supposed to do, even if you find a vaginal nodule, suburethral vaginal nodule, you are not supposed to do a biopsy because it leads to torrential hemorrhage and patient may even die on the table. So we have seen people becoming bad in the OPs, thinking that it is cervical cancer spreading to the vagina and trying to take a biopsy. So no histological proof is necessary. It is the treatment, the diagnosis and treatment is based only on hormonal diagnosis, that is serum beta HCG. Persistent or rising titers in the absence of pregnancy. Always remember that whenever you are following a case of vesicular mole, those are patients, you find the HCG titers are rising. Initially, there is a fall and then the HCG starts rising. Always first you have to exclude a new pregnancy. So that's the reason why you have to put the patient on contraception so that the rising titers will not interfere with your HCG surveillance, right? So always, whenever the woman has HCG positive in the absence of a pregnancy, it always indicates a trophoblastic neoplasm. Then ChorioCarcnoma produces abundant amounts of HCG, which can typically range from 100 to over 1 lakh milli units per ml, depending upon the size of the tumor or extent of the disease. And the metastatic brain lesion is suspected whenever the ratio of beta HCG in the spinal fluid serum is more than 1 in 60. But of course, we are not doing any CSF analysis nowadays to detect brain mets. Now that CT and MRI are available, all mets can be easily diagnosed by doing a CT or an MRI, CT brain, CT lungs, CT abdomen. So it's easy to detect. It's a non-invasive investigation to diagnose the mets. Right. So previously, when CT and MRI were not available, they used to do a CSF. So if the ratio between the CSF and the serum is more than 1 in 160, more than 1 in 60, then they used to suspect a brain lesion whenever the woman is having neurological symptoms and then the HCG is positive. So now it's not necessary. You just take a CT, it will show you the lesion in the brain or in the liver, spleen, gastrointestinal tract, anywhere in the body. So laboratory test, always complete blood picture is important. It may show you anemia. Not only for that, you should also have a pre-treatment evaluation. Once you start the chemotherapy, you should have something to compare. So do a complete blood picture to detect anemia and also as a pre-treatment counts before starting the chemotherapeutic regimes. Then LFT may be elevated if there are mets in the liver. And thyroid function test also should be done because if you know that HCG always stimulates thyroid. So patient may have hyperthyroidism because of increased HCG. And other investigations are mainly because of to detect the mets and the size of the tumor. So regardless of the imaging modality used, that is, what are the imaging modalities we are using? You can use ultrasound, right, to detect the mass in the uterus, head, neck, anywhere than the pelvis, and in the liver and the spleen. Then you can take an X-ray just to detect the mets in the lungs. You can do a CT MRI of the brain, lungs, abdomen, and pelvis. So whatever imaging modality is used, always choriocarcinoma appears as a mass enlarging the uterus. You can always find the enlargement of the uterus. Sometimes it manifests as a discrete central infiltrative mass. Okay? And the appearance, heterogeneous appearance correlates with the necrosis and hemorrhage. Plain X-ray chest may show the secondaries in the form of cannonballs or a snowstorm appearance. Right? For liver, for lung mets, because lung mets are seen in 80% of the cases. So this is how you can find the mets in the X-ray, plain X-ray chest, which is very can be taken very easily, not very expensive. Then ultrasound to detect the tumor, cystic ovaries, and also to exclude any remnants of conception which are producing HCGs. Then in choriocarcinoma stage 3, the endometrial cavity will be filled with a hyperechoic masses. Then CT scan for the liver, lung, brain, and bone. Micrometastasis may be present in 40 to 45% of the cases. In non-metastatic gestational trophoblastic neoplasia, which have a normal chest radiograph findings. So though you take an X-ray chest and find it normal, in spite of that, half of them will have micrometastasis, which cannot be detected by the routine chest radiograph. Then brain mets. So brain mets can be easily located on a CT. Right. So diagnostic uterine curettage, there's no need to do an curettage. I've already told you histological biopsy is not required, unlike any other cancer in the body. So pre-therapy DNC reduces the intrauterine tumor bulk, but however, it is not used for routine histological diagnosis. There's no need. And brisk hemorrhage can occur for a while. Then you may have to do a hysterectomy, life-saving hysterectomy have to be done. So don't touch the tumor. If you try to remove a piece, then torrential bleeding will start and you may have to remove the uterus. You have to do a life-saving hysterectomy. So there is no need to do a diagnostic uterine curettage. Histological diagnosis is, I'm emphasizing again and again, because this is the only cancer in the body which doesn't require a histological diagnosis, right? Then treatment, actually the disease is classified into non-metastatic disease, then low risk metastatic and high risk metastatic disease. Okay, non-metastatic, low risk and high risk. Non-metastatic and low risk metastatic can be treated with a single agent chemotherapy. Right. So treatment of non-metastatic choriocarcinoma, that is JTN, is hysterectomy is advisable as an initial treatment in elderly individuals who no longer wish to preserve the fat. It is not a must that hysterectomy has to be done in young patients. If the woman is already a multipara, she has finished her childbearing, you can do a hysterectomy because it will remove the bulk of the tumor. So that the advantage is it will reduce the number of chemotherapeutic courses that are necessary. So the duration of chemotherapy can be reduced, but it is not a must. If the patient is young, she can still have children. So that is one colorful aspect of choriocarcinoma, unlike other carcinomas, where this patient can still have children if she wants to after she completes her chemotherapy. So that is the beauty of this cancer. So the choice, the advantage of doing a hysterectomy in an elderly individual of finished childbearing is it will reduce the number of chemotherapeutic courses which are required, and the duration of chemotherapy will be reduced. So adjusted single agent chemotherapy at the time of surgery is indicated to eradicate any occult metastasis and reduce the tumor dissemination. That means you have to do under chemotherapeutic cover. When you are doing surgery, it is essential that you give one course of chemotherapy and start surgery, so that you will reduce the tumor dissemination. Any occult metastasis, if it is present, it will be eradicated. So always hysterectomy in elderly individuals who have completed the childbearing under cover of chemotherapeutic agents. Okay. So WHO prognostics, that is the scoring system. So this scoring system is predictive of the clinical outcome, right? So if the score is 0 to 6, this I have already told you. It is called a low risk metastatic choriocarcinoma, right? And so the low risk, the resistance is also less for single agent chemotherapy. So wherever the score is more 7 or more, it predicts a high risk of resistance to monotherapy. So these patients require a combination chemotherapy, not a single agent chemotherapy. So 0 to 6, you can low risk metastatic disease can be treated with single agent, whereas high risk metastatic, that is a score of 7 or more, they require a combination treatment. So single agent chemotherapy is the treatment of choice for the patients who are wishing to preserve their fertility, because most of them are young patients. They had a vesicular mole and within 2 years they have developed a choriocarcinoma. So these are the patients who are wishing to preserve their fertility. So you can start them. The treatment of choice is single agent chemotherapy. You can use, usually methotrexate is the preferred single agent. If there are any contraindications for methotrexate, like any liver dysfunction or kidney problem, if it is contraindicated, then the second line of drug which can be used is actinomycin D. So these are the single drug agents which are usually used as chemotherapeutic agents. So you have to continue the treatment every 2 to 3 weeks. So depending upon the response of the patients, not it has to be tailor-made. It depends on how the patient has adjusted to the previous course of chemotherapy. Has she recovered very well? So you are supposed to start the second cycle only after the patient has recovered. So every 2 to 3 weeks, depending upon the response of the patients, you have to continue until you get a 3 consecutive normal HCG levels. That means negative HCG levels have to be obtained. So the cycles have to be repeated depending upon the patient's response to the chemotherapy, right? And so the cycles have to be continued until 3 consecutive negative levels are obtained. And after negative levels also, you have to add 2 more cycles. 2 more courses should be given after the first normal HCG level, so that any micromets are present, they will be tackled by giving the 2 more courses. So this is the treatment schedule for non-metastatic or low metastatic. Low risk GTN, low risk choriocarcinoma is FIGO score is 6 or less. Single agent chemotherapy is most commonly used regime. The 2 methotrexate is most commonly used at the dose of 1 milligram per kg body weight IM, or can be given IV also. So you give it on alternate days, 1, 3, 5, 7, right? Alternate days. So in between the days, you have to give folinic acid, because you know methotrexate is a folic acid antagonistic. So this is a folinic acid rescue. So 0.1 milligram per kg body weight IM in between days, 2, 4, 6, 8, right? So the side effects of methotrexate, all of you know, any anti-metabolite will cause stomatitis, peptic ulcerations, gastric hemorrhage, then dermatitis. Then most important is bone marrow depression. Okay, so leukopenia, anemia, thrombocytopenia, all those things will be there. Then actinomycin D is the second drug of choice. It is used as a primary therapeutic agent if methotrexate is contraindicated. So otherwise, in all cases, methotrexate is the drug of choice unless it is contraindicated. So give 1 milligram per kg body weight 1357, folinic acid rescue 0.1 milligram per kg body weight IM, and 2468. So actinomycin D only if methotrexate is contraindicated, like in liver dysfunction, renal dysfunction, and so, or if there are severe side effects. In such cases, you have to go for actinomycin D. So this is a mono agent therapy for non-metastatic or for low risk metastatic diseases. So the remission rate is very high. Around 90% of the individuals will undergo remission. So the same cycle need to be repeated again. See this cycle, this is a cycle. This cycle has to be repeated again after 2 weeks or 3 weeks, depending upon the response of the patient, how well she has tolerated, what is the WBC level, what is the RBC level, what is the platelet level, and so on. So depending on that, repeat the cycle every 2 to 3 weeks until HCG level 3 consecutive HCG levels are negative. And after that, 2 more courses have to be given to attack the micrometastasis. Right? So the remission rate is very high, 90%, as high as 90%. Only 10 to 15% of the patients will require a combination chemotherapy with or without surgery to achieve remission. That means 90% of them will have a remission. Only 10% will require another agent or a combination chemotherapy for achieving a remission. So single agent chemotherapy with either actinomycin or methotrexate has achieved comparable excellent remission rates both in non-metastatic and low-risk metastatic choriocarcinoma, that is in GTNs, right? So actinomycin D or methotrexate has got a comparable results, excellent remission rate, that is around 90% are the remission rates. So supposing the patient has not responded to single agent, that is only in 10% of the cases, they don't respond to the single agent. The HCG titer keeps rising or it doesn't fall at all. In such cases, you have to go to a combination regime, which is known as a MAC regime. MAC means methotrexate, actinomycin D, and cyclophosphamide. Okay. So methotrexate, same thing. Again, 1 milligram per kg, IM or IV 1357. Folinic acid rescue 0.1 IM 2468. But you are adding 2 more drugs. That is why you call it as combination drugs. Actinomycin D 12 micrograms per kg IV. Every day you have to give for 5 days, 1 to 5 every day. In the same way, cyclophosphamide and 3 milligrams per kg body weight IV 1 to 5 every day. So this is a MAC regime which is given for 1 week. Methotrexate and folinic acid are alternating, whereas actinomycin D and cyclophosphamide are given daily from 1 to 5 days. And then the follow-up is the same again. So every 2 weeks you keep repeating the cycle till HCG becomes consecutive 3 negatives, and after that repeat another 2 cycles to attack the micromets. So surveillance, how do you follow up this patient while on treatment? So do a weekly HCG titers, complete blood picture, particularly leukopenia, thrombocytopenia, anemia, and so on. Then LFT, RFT, chest X-ray, etc. The cycles have to be repeated every 2 to 3 weeks, depending upon the recovery. So never repeat the cycle unless the patient has fully recovered, right? Till 3 consecutive negative HCG sets. Later continue for 2 to 3 cycles more to attack the micromets. This I have already told. So that is about non-metastatic and low-risk choriocarcinoma. So what about high risk? High risk cases, we have already learned that they don't respond to single agent. All of them require a combination chemotherapy. Multi-agent chemotherapy with or without adjuvant radiotherapy, depending upon the meds, or surgery should be the initial treatment for patients with high risk metastatic GTD and GTN. Okay. So the most commonly used regime is EMACO regime. This is a good choice for high-risk metastatic gestation neoplasms. So along with that, you can combine adjusted surgeries like wherever the removable foci. You can remove those chemotherapy-resistant diseases. Controlling the hemorrhage may be one of the treatment regimens. So along with chemotherapy, you can even add radiotherapy or removal of that particular lesion. Right, so this is the chemo. This will be there in your textbooks. You have to just by heart at EMACO regime. So there are many more regimes, like you also have a EMACO, EMA, and EP regimes. Then now platelet axial regimes are also there. So many regimens are there, but for undergraduate purposes, it is enough if you know about the MAC regime and EMACO regime. These 2 regimes, if you know, it is more than sufficient, right? So this is there in your books. You just remember what are all the drugs that are used. So EMACO regime, E stands for etoposide, M stands for methotrexate, and A stands for actinomycin. Then C stands for cyclophosphamide, O stands for oncovin or vincristine, right? So the day 1 you give EMA, that is etoposide, methotrexate, and methotrexate again. Then actinomycin D. Day 2, you give only etoposide and folinic acid and actinomycin D. Right? So etoposide dose is 100 milligrams per meter square IV over 30 minutes. Methotrexate also the same dose, but IV bolus, not 30 minutes. Then another methotrexate also has to be given as an infusion continuous, 200 milligrams per meter square IV as 12 hours continuous infusion. So everything is given in the book, so you just have to mug it up, that's all. And actinomycin D is 0.5 milligrams IV bolus. That is on day 1. So you are giving etoposide, methotrexate bolus as well as IV infusion, then actinomycin D bolus. Then on day 2, you don't repeat methotrexate because already you have given one bolus and you already have given continuous infusion for 24 hours. You don't give it methotrexate. So you only repeat etoposide because you have given methotrexate. Next day you have to give folinic acid. Okay. Then actinomycin has to be repeated again. So the same dose, etoposide and actinomycin D is repeated in the same doses. Folinic acid is given as a rescue, 15 milligrams IV, IM or oral every 6 hours for 4 days. So that's about day 2. Then wait for 1 week. On day 8, now you have administered, EMA has been administered. Now the day 8, you have administered the CO. That is cyclophosphamide 600 milligrams per meter square IV over 30 minutes. And vincristine or oncovin 1 milligram per meter square up to 2 milligrams IV bolus. Right? So this is EMACO regime. You have to remember there are many more regimes which may be given in different books. But don't break your heads trying to remember all those things. EMA, EP regimes, TP regimes, and so on. Right? So therapy is based upon the risk criteria, which we have already learned. Repeat each regime in sequence every 14 days. So all this whole thing has to be repeated every 2 weeks as toxicity permits. In case of CNS metastasis, increase the dose of infused methotrexate to 1000 milligrams per meter square. So instead of giving only 200, if there are CNS mets, you have to increase it to 1000 milligrams per meter square IV infusion over 12 hours. Right? And the folinic acid has to be given every 6 hours. So this regime is called a high dose methotrexate EMACO regime. So when there are CNS mets. So just remember EMACO regime and the MAC regime which you have just learned. That's more than sufficient at your levels. So monitoring, again the same thing, HCG levels weekly till they become negative. Then after they have become negative, do every 2 weeks for 3 months, later on every month for 1 year, and every 6 to 12 months for life or for at least 5 years. Right? Okay. Then assessment of response. So whenever the patient is on chemotherapy, serial measurements, the weekly, bi-weekly, single agent issue treatment has to be continued. When infusion methotrexate is given as a one-time dose, so when combination chemotherapy with EMACO regime is used, the regime has to be repeated every 2 weeks. The role of surgery. Role of surgery, total hysterectomy can be done if required. That is, we have already told. And elderly individuals who have completed their childbearing and so on. Ovaries are usually not involved. And even if they are involved, they can be effectively cured with post-operative chemotherapy. So there is no need to remove the ovaries. So no need to do a bilateral salpingo-oophorectomy, right? Only total hysterectomy can be. Then indications are more than 35 years, not desirous of fertility, intractable vaginal bleeding. You try to do a biopsy and then she started bleeding, so life-saving hysterectomy. Then localized uterine lesion, which is resistant to chemotherapy. Accidental uterine perforation when you are doing a curettage. So these are all the indications for them. Then localized resection, we have already mentioned that localized resection can be combined with the chemotherapy. So lung resections, most frequently used surgical procedure, extirpation of lung mets, that is thoracotomy with pulmonary wedge resection. So however, it is not always necessary to resect the lung mets in majority of these patients. So only in highly selected patients with drug resistant diseases. So only if the woman is not responding to the treatment regime, you call it as a drug resistant disease, then only you try to do a resection of pulmonary nodules. Otherwise, routinely it is not indicated. Then craniotomy, brain mets are seen in around 9 to 20% of the cases. So this has got a worst prognosis. So these lesions tend to be highly vascular. They have a tendency for necrosis and hemorrhage. So brain irradiation is integrated into the treatment of brain mets, right? To prevent hemorrhage and neurological deterioration. So chemotherapy is combined with brain irradiation, or sometimes craniotomy can also be used only to prevent acute deterioration. So if the tumor is expanding in the brain, you can do a craniotomy and give some space for the brain to expand till the chemotherapeutic agents diminish the tumor volume. So brain irradiation can be combined with so brain metastasis. Patients with brain metastasis require whole brain irradiation, 3000 centigrade over 10 days. Then intrathecal high dose methotrexate has also been used to prevent hemorrhage and tumor shrinkage. So that is as far as the brain mets are concerned, either hemorrhage, either craniotomy or brain irradiation or intrathecal high dose methotrexate. Then liver mets, intervention radiology, along with hepatic artery ligation or embolization or whole liver irradiation, 2000 centigrade over 10 days, along with chemotherapy may be effective. So both brain as well as hepatic metastasis, they have a very poor prognosis. So follow-up, all patients with stage 1 to stage 3, all these patients should receive follow-up with weekly measurements till they are normal, monthly for 12 consecutive months, and effective contraception during the follow-up. Cure rate is almost up to 100% in low risk and about 70% in a high risk metastasis. So recurrence in a previous 1 molar pregnancy is 1 to 2%. 2 or more, it is 15 to 20% recurrence. So overall prognosis is very good in ChorioCarcnoma when compared to any other cancer in the body. And more important is that the woman can become pregnant and have children later on. So that's about ChorioCarcnoma. Thank you for your patient hearing. Now you will have a next class. You have to bear with me for another 1 hour, I think so. It's 10 o'clock. Yeah, I'll finish off in another 1 hour. That is RH negative pregnancy. I don't know where to stop. Yeah. Yeah. Can you see all of you? Hello, hello. Ah, very good. No response from any one of you, Ra. Era, నాకు ఎలా తెలుస్తుందన్న మీకు అర్థమవుతుందో అర్థం కావట్లేదో. Okay, so this is the obstetric topic. Till now you have heard an oncology topic. Very interesting, is it not? ChorioCarcnoma is very interesting. Of course, it is unfortunate for any woman to have any carcinoma, but of all the cancers, that is supposed to be the have got good prognosis. Now, RH negative pregnancy, right? So all of you know that whenever the woman is RH negative, so blood group and RH typing is the initial investigation you do at the first booking, is it not? Whenever the woman comes for the antenatal OP for pregnancy confirmation, the routine investigations you do, one of them is blood group and RH typing. So what is the importance of doing an RH? Because of isoimmunization, right? So RH antigen was first discovered in the year 1940 by Landsteiner and Wiener. So it was first discovered in rhesus monkeys. So it was called RH, capital R and small h. So an individual having the antigen is called an RH positive and the one who doesn't have are called Rh negative. Okay, the incidence is very less, around 5 to 10%, more or less in South India. So among the Rh antigens, we have three subgroups, that is C, D, and E, out of which D is most antigenic. So we have three isoforms. We have capital C and a small c isoform. You have capital E and the small e isoform, whereas the capital D doesn't have a small d isoform. So totally we have only 5 Rh antigens: C, C, D, E, and A. So all these 5 antigens are known as the Rh antigens, out of which D is supposed to be the most potential and most antigenic of all the three, right? So all these antigens are under the genetic control of short arm of the chromosome 1. So D has one gene, the control is by one gene on the short arm of chromosome 1, whereas C and E commonly have one gene. They both have one gene, whereas only D has a single gene for its production on chromosome 1 short arm, right? So D is supposed to be the most potent and expressed very early in gestation, right? So depending upon the antigen that is present, you call them as heterozygous or homozygous. So if the father is having both the capital D's, you call them as homozygous. If he has only one D, because you don't have an isoform of small d, has only one D, then you call him as a heterozygous individual who has a 50% chance of passing the Rh negative genes to the offspring. Whereas homozygous, all the offspring will be positive. I think you know this basic fundamentals. Right. Okay. So what happens when the Rh negative woman is carrying an Rh positive fetus? She is exposed to the fetal red cell antigens for the first time, right? So that is known as isoimmunization or alloimmunization. So iso or alloimmunization means it's an immune response against a non-self antigens from a different individual of the same species, right? So allo or isoim, previously this was called as an isoimmunization. Now they are calling it as alloimmunization, both are same. So alloimmunization means an immune response to non-self antigen. If it is against a self antigen, you call it as autoimmune disease, is it not? If the antibodies are produced against our own self antigens, you call it as autoimmune. Alloimmune means immune response which is generated in response to non-self antigens. But the non-self antigens are from a different individual belonging to the same species, human species, is it not? But the individual is different because the fetus has half paternal and half maternal, is it not? One chromosome is from the mother and the other one is from the father, is it not? So this is known as alloimmunization. That is an immune response generated to non-self antigens from a different individual of the same species. Now here what is happening? The mother is Rh negative, the baby is Rh positive because the father is positive. So some of these red cells, they enter into the maternal circulation. So the mother gets exposed to the fetal red cells containing the Rh antigen, which she doesn't have. Our red cells do not have the Rh antigen. Whereas the fetal red cells which are escaping into the maternal circulation, they have this Rh antigen. So for the first time, the maternal immune system is exposed to a foreign antigen, okay, non-self antigen from a different individual of the same species, okay. So the immune system of the mother will recognize this foreign antigen, and initially there is only sensitization. Later on, she will start producing the antibodies. Initially, she gets only sensitized. Later on, she gets immunized and starts producing the antibodies. So the antibodies which are produced will stay for life in the maternal serum, right? So it takes from some time, just like a vaccine, it takes at least 2 to 4 months for the antibodies completely to be produced. And the escape of the fetal blood into the maternal circulation usually occurs in the last trimester and mostly at the time of delivery. So that's the reason why the first baby is usually not affected, because it takes time. It takes at least 2 to 3 months time for the antibodies to develop in the mother. So the first pregnancy, the first baby usually escapes. It's only the problem starts only from the second pregnancy onwards when she is carrying a positive fetus. Followed all of you? So how does this sensitization or immunization or exposure to fetal exposure to positive antigen occur? It can occur due to mismatch of blood transfusions, so which is very, very rare nowadays. Because nowadays, unless you do an ABO and RH typing, we don't transfuse blood. But sometimes it may occur inadvertently or confusion. So mismatch of blood transfusion is one way of the mother getting exposed to the fetal to the RH antigen, and pregnancy is the most common way of getting sensitized and immunized. RH negative mother carrying an RH positive fetus because her father is positive. So then prevalence, though the RH negative population is around 5 to 10%, but the prevalence of the disease is less than 1%, right? That is supposed to be because of various other factors which affect the production of antibodies, right? Maybe the antigen itself is weak. Antigenicity of the antigen is very weak in our population. That is, antigenicity means ability of the antigen to produce antibodies. That's called antigens. Probably our RH antigens are very weak. They are unable to induce a sufficient immune response. Or the mother may be a non-responder. So that is genetically inherited, non-responders. Non-responder means though the antigen is there in her circulation, she will not respond by producing the antibodies. Okay. So these are some of the causes for the disease being very rare in our country, particularly Asian population. And though we do have, so as per theoretically, every RH negative woman carrying a positive fetus should have this problem. Is it not? But doesn't happen in every case. So if some of you girls are negative, so don't think this problem will occur in every individual. So it's very, very rare because of low antigenicity, non-responders, okay, low amount of FMH which is occurring, all those things. So what are we doing to prevent this immunization? All women who have delivered a positive baby, they are immunized prophylactically with anti-D immunoglobulin, is it not? All anti-D women, this is primary prevention. How do you prevent immunization of the mother? By giving anti-D immunoglobulin immediately after delivery. Supposing you don't give this immunoglobulin, 16% chance of developing immunization, right? So 2% will be sensitized by the time of delivery. 7% will be delivered as will be immunized by 6 months after delivery. The remaining 7%, they are only sensibilized, producing detectable antibodies only in a subsequent pregnancy. So in the absence of routine prophylactic anti-D immunoglobulin, the chances of the newborn having alloimmunization is only 16%, right? Suppose another important factor which acts against the immunization of the mother is ABO incompatibility. If there is an ABO incompatibility between the mother and the baby, then all the cells will be destroyed before they can produce, before they can sensitize the immune system of the mother. So if there is ABO incompatibility, then the risk of immunization is only 2%, even without prophylaxis. Followed all of you? So without prophylaxis, the chances of immunization are 16%. If there is ABO incompatibility, the chances of risk is only 2%, even without prophylaxis, right? So when does fetal RH antigens appear? Around about the 38th day, that is after 1 month after conception, and a fetal blood group can be confirmed around about 9 weeks, that is second month. So how do you know the fetal blood group? Either you have to take a sample from the trophoblast by doing a chorion villus sampling, CVS, chorion villus sampling, or by doing an amniocentesis at 16 weeks. So that's how you can confirm the blood group and RH typing of the fetus. Then nowadays, because of to prevent all these invasive techniques like CVS and amniocentesis, we have a circulating cell-free fetal DNA in the maternal plasma. This is gaining more and more importance nowadays for prenatal diagnosis of congenital anomalies, chromosomal anomalies. Likewise, even blood group can also be blood group and RH typing can also be detected by examining the circulating cell-free DNA in the maternal plasma. So this is now gaining importance for all prenatal diagnosis, right? So there are two phases: initial sensitization followed by immunization, right? So initially only IgM antibodies are produced because they are large molecule. They don't cross the placenta. So later on, IgG antibodies are produced, which cross the placenta and start immunizing the fetal cells. So what is the pathophysiology of RH isoimmunization? So ABO compatible. Okay, that means mother and fetus have the same ABO blood group. The RH positive fetal cell will enter into the maternal circulation and remain in the circulation for the remaining lifespan, right? After which they are removed from the circulation by the RES and broken down and liberate the antigens, right? So maternal antibodies will be formed against the fetal RBCs antigens which cross the placenta. Then they cause fetal red cell lysis and then anemia in the baby. So detectable antibodies usually develop 2 weeks following a large volume of feto-maternal bleed, feto-maternal hemorrhage, which is called FMH. But if the FMH is less than 0.1 ml, then the antibody may not be detected unless it is boosted by further RH stimulus. That means another FMH or another pregnancy, right? So the antibodies will be formed 2 to 3 weeks after a large FMH. If the FMH is very less than 0.1 ml, then not sufficient antibodies are produced unless there is another booster trigger of RH stimulus, either in the form of another FMH or the next pregnancy or whatever. There are two types of antibodies are produced, IgM and IgG. I have already told. IgG will cross the placenta. Antibodies once formed will remain throughout the life, right? So if the fetus is RH negative, they don't have any effect because the negative fetus will not have the antigen. The problem is only in RH positive fetus, which has the antigen. Then antigen-antibody reaction will occur in hemolysis, anemia, jaundice, all those things. Okay. So the IgG antibody develops usually after 6 months. Meanwhile, the baby will be delivered. So the chance of first baby getting affected is very less. So the next pregnancy, there will be anamnestic response. IgG crosses the placenta, damages the fetal RBCs, and causes the manifestation of hemolytic disease of the fetus and newborn, right? So depending upon the degree of agglutination and degree of destruction of the fetal RBCs, you have different grades of fetal hemolytic disease, right? Like, the severe form is hydrops fetalis. Next comes icterus gravis neonatarum leading to carnitaris, and then congenital hemolytic, that is the mildest form. So these are the three forms. Severest form is hydrops fetalis. Moderate form is icterus gravis neonatarum leading to carnitaris. Then the mildest form is congenital hemolytic anemia in the newborn. So this is this extra grandmother theory or grandmother syndrome explains then affection of the first baby also. That is, the mother in utero has been exposed to the maternal antigens, and then the antibodies have been produced. And then when she becomes pregnant, and then the antibodies will cross, and that's how even the first baby can be affected. It is known as a grandmother theory. Okay, followed all of you? Sensitization in utero. The mother gets sensitized in utero from her mother. So that means grandmother. That is called grandmother theory. Will explain the involvement in the primates. First fetus getting affected. So what are the factors involved affecting the alloimmunization? So though the prevalence of RH, I have already told you, though the prevalence is more, the isoimmunization is very uncommon, right? Hardly it is less than 1% because of immunological non-responders. So this is genetically inherited non-responders. Then insufficient passage of fetal antigens across the placenta or antibodies across the placenta. Then coexistence of ABO incompatibility. So that rapid clearance of fetal erythrocytes before they can elicit an immune response. Then antigenicity is variable. Maternal immune response to antigen is variable. Then most important factor affecting the alloimmunization is the volume of FMH. If the volume of FMH is very low, less than 0.1 ml, then the antibody formation is very less, hardly detectable. So these are the factors affecting the alloimmunization. So if some of you are Rh negative, so don't get worried that this problem will occur in every woman, every one of you. So sensitizing events are first and second trimester miscarriages, ectopic pregnancies, vesicular, any invasive procedures which are done like chorion villus sampling, amniocentesis, fetal blood sampling, right? Then late pregnancies, external cephalic version, APH, placenta previa, abruptio placenta, and any internal podalic versions, any vehicular accidents, abdominal trauma, blunt trauma, okay, all those things, knife injuries, whatever, homicides, suicides, and so on. All those things are sensitizing events, right? Then the incidence of FMH increases with increasing gestational age, and it is highest during delivery. So the maximum FMH will occur at the time of delivery, right? And the risk factors for postpartum FMH are cesarean delivery, manual removals of placenta, intrauterine manipulations, then multiple gestations, antepartum hemorrhage, stillbirths, IUFDs, and so on. So these are all the risk factors for intrapartum or postpartum FMH. So most often the FMH maximum occurs during delivery. So cesarean deliveries, manual removals, intrauterine manipulations in the form of internal podalic version and so on, multiple gestations, abruption and placenta previa, stillbirths, all those things will increase. So once the fetal-maternal hemorrhage is recognized, the volume of how much of FMH has occurred has to be estimated so that you can calculate the appropriate dose of anti-T immunoglobulin for prophylaxis. But in all cases, we don't calculate the amount of FMH. We all mothers who have delivered an RH positive baby, they are given 300 mics of anti-D. There's no need to calculate. The 300 mics of anti-D is supposed to counteract 30 ml of whole blood or 15 ml of RBCs. So usually the FMH will not be more than 30 ml. So 300 micrograms will be sufficient to counter the FMH which has occurred. And normally without any other sensitizing events like external cephalic versions, internal monitorings, and so on. So one way of estimating the fetal-maternal hemorrhage is known as Kleehar-Bethke test or BK test or KB test, which is a quantitative test. It's also called acid dilution test. So where the smear is done fixing with 80% ethanol, hematoxylin, and eosin. So the interpretation is fetal hemoglobin will be resistant to the acid. So it will appear as all these red cells. So whereas the maternal RBCs appear as ghost cells because they are susceptible to the acid, right? So you have to count the number of fetal cells which you can see in 50 low power fields. So if you can find 5 fetal erythrocytes in 50 low power fields, so that usually represents 0.5 ml of FMH. Right? So like that, you have to calculate the FMH. There are also some formulae to calculate, but there's no need for you. Just remember that There is a method to calculate the FMH based on the KB test or Lehigh Bethke test, but usually it is not done. For all women who delivered a positive baby are given 300 mics, which can contract 30 ml of FMH or 50 ml of RBC, right? So that if you blindly remember, it is more than sufficient. Another test which can be used are the flow cytometry, which is more sensitive and accurate, and Rosette test, which is a qualitative and screening test. So usually it is negative if FMH is less than 2 ml, and the standard dose of 300 mics is usually sufficient. Right? So routinely these tests are not done, but somebody asked you, you may. So the fetal manifestation I've already, most severe form is hydrops fetalis. Next is icterus gravis neonatal and congenital hemolytic anemia of the newborn. Hydrops fetalis is the most serious form. All of you know, destruction of the fetal red cells will lead to severe anemia, hypoxia, acidosis. So adverse effects on heart, brain, and placenta, hyperplasia of the placenta. Okay, to increase the transfer, but the availability of fetal red cells are progressively diminished because of hemolysis. So liver damage, hypoproteinemia, generalized edema, ascites, hydrothorax. Okay, fully blown up fetus. That's why I called it as hydrops. So male fetuses are supposed to become more likely, they are likely to become hydrops, and most of them die in utero or they die immediately after birth. There's no way of to salvage these babies unless you do an intrauterine transfusions. So there will be accumulation of extracellular fluid in at least 2 body compartments like ascites or pleural effusion, pericardial effusions, and so on. Right? So this is typically a hydrops fetalis baby. So diagnostic features, mother is negative, presence of antibody may be there, presence of polyhydramnios. So the mother may have polyhydramnios, hypertension, placenta previa, all those things. It's known as a mirror syndrome. So what is happening in the mother, baby, the same thing is happening in the mother also. It's called mirror syndrome. Ultrasound to detect edema in the skin, scalp, pleural cavities, pericardial cavities, echogenic ball, Buddha position. It's called a Buddha position because the edematous scalp will appear as a halo around the fetal head. That's why it's called a Buddha position, just like Buddha. So the baby appears very pale and edematous, enlarged abdomen, ascites, placenta is very pale and edematous. Placental weight will be equal to fetal weight, that means a large placenta, because it has to serve its purpose of increasing blood supply. Then fetus is not hydropic, then the placenta may look normal. Icterus gravis neonatal is pathological jaundice which develops within 24 hours. Here the baby is born alive without jaundice, but soon develops jaundice within 24 hours. While fetus is in utero, there is liberation of unconjugated bilirubin. It goes into the maternal system, right? So in utero, the baby will not develop jaundice. So only when the cord is clamped, when the liver is asked to conjugate all this unconjugated bilirubin, then it will not be able to do so, and then the baby will develop jaundice. So premature baby all the more because of the prematurity of the. So when the bilirubin level rises to around 20 mg/cent, it crosses the blood-brain barrier and produces kernicterus. So damages the basal nuclei of the brain permanently and produces kernicterus. Then the mildest form is congenital anemia of the newborn, hemolytic anemia. So this is a mild form where the hemolysis is going on slowly. Anemia develops slowly within the first week of life. Jaundice is very mild or not evident. So the destruction will continue as long as the antibodies are available. So maybe up to 2 months or so on. So there will be hepatosplenomegaly, which are the sites of extramedullary erythropoiesis. So this is known as the congenital hemolytic anemia of the newborn. Then effects on the mother, so increased incidence of preeclampsia, polyhydramnios, large baby, postpartum break. This is known as a mirror syndrome. Maternal mirror syndrome, generalized edema, proteinuria, pruritus, cholestasis. So prevention, primary prevention is always to prevent immunization of the mother. That is by administering anti-D immunoglobulin within 72 hours, right? In some centers, though we are not following routinely, in some centers, routine antenatal anti-D prophylaxis. Routine antenatal anti-D prophylaxis is given 300 mics at 28 weeks. Some of them they give 2 doses also. 1 dose at 28 weeks, the other dose at 34 weeks. Because it is expensive, we are not giving. This is only for non-immunized pregnant women. Apart from this, it is recommended that anti-D should be given after sensitization, even before delivery, after abortions. So antenatal anti-D prophylaxis can be given either 1 dose or 2 doses at 28 weeks and 34 weeks. Then after delivery within 72 hours. This is primary prevention. And then calculation of volume by kb test not done. Generally, the dose of 300 mics will protect FMH up to 30 ml of fetal whole blood. Okay. Then miscarriages, first trimester miscarriage, 50 mics. But after 12 weeks, second trimester miscarriages, again 300 mics. Okay. Then to prevent secondary. Prevent and minimize the fetal-maternal blood. Take precaution during cesarean section. Avoid spilling of blood. Avoid prophylactic heterotonics. Avoid manual removals of placenta. Then do amniocentesis after proper localization of placenta. And most important is to avoid mismatched transfusions. So what do you do when you have an RH negative mother and immediately test the husband's blood group if he is positive? Of course, we are not doing any genotype nowadays. Okay, do a serial antibody test in the mother. It is indirect Coombs test. So if the woman is not having any antibody, she is non-immunized, non-sensitized. So all the women can be divided into 2 groups, sensitized women and unsensitized women. Unsensitized women, there will not be any problem. Suppose more so she is a primary gravida. So repeat the ICT at 36 weeks again, because FMH is more common in the last trimester. So first you have repeated at the first booking. If it is negative and if she is a primary gravida, then repeat the test at 36 weeks. If it is negative again, then all these women, RS negative women, don't allow them to go into post-terms. Always deliver at term, all these women. Okay, right. So supposing the patient is already immunized, indirect Coombs test is positive, right? You have to do the titers at weekly intervals. It has to be done, and whenever the titer exceeds 1 in 16, right? We do a serial ACTs in dilutions, so that as long as the titer is less than 1 in 16, it is okay. You follow up by weekly ACTs. Whereas once it crosses 1 in 16, that means the baby is affected. So you have to do either an amniocentesis and test for fetal bilirubin, serum bilirubin, amniotic fluid bilirubin, or nowadays it has been replaced by MCA PSV. So you have to do Doppler, MCA PSV study every 1 to 2 weeks. So that will be calculated in multiples of median MOMs. So more than 1.5 MOMs indicates affection of the fetus. Then also do a serial ultrasound every 2 to 3 weeks from 20 weeks onwards. Supposing the antibody titer is rising, MCA PSV is more than 1.5 moms, our ultrasound is showing an abnormal fetal ascites, hydrops, and so on, then indirect Coombs test is invariably negative in such cases. Then what do you do? So do a cardiosynthesis, right, for fetal hematocrit, fetal blood group RH typing, bilirubin, and so on. So previously we used to do amniocentesis and test for bilirubin, but now we have a more easy non-invasive test. Okay, you can always do MCA PSV more than 1.5 multiples of medium. So that is the best test to tell us about the fetal affection. So in some cases, cardiosynthesis has to be done to know the fetal hematocrit, fetal hemoglobin, serum bilirubin, and so on. So if the more so if the baby is nowhere nearing term. Supposing it is only around 28 weeks, you cannot deliver it. So in such cases, the only way to make this baby survive is intrauterine transfusions. The purpose of intrauterine fetal transfusion is to raise the hematocrit at least to 50% and repeat the transfusions every 1 to 2 weeks up to 34 weeks and then deliver the baby, right? So don't give any prophylactic methods, do a early cord clamping and collect the cord blood for hemoglobin percentage, ABO, RH typing, hematocrit, reticulocyte count, direct Coombs test, bilirubin, peripheral smear, and so on. So all these babies have to be delivered in specialized units, those who need intrauterine transfusions. Okay. So if you don't have facilities to do a cardiosynthesis, then you can do an amniocentesis and do bilirubin and plot the bilirubin into the Lilly's charts. So do an amniocentesis and do a spectrophotometric analysis of the amniotic fluid. So when you are doing a spectrophotometric analysis at 450 nanometers wavelength, if bilirubin is, normally it should be a straight line like this. If bilirubin is present, there will be a bulge, right? The graph will show you a bulge at 450 nanometers. So measure the bulge, okay? This measure the deviation. This is called optical density difference, ODD, at 450 nm. Deviation bulge. So this deviation bulge is measured and then it is plotted onto a graph. So this graph has got the vertical is ODD at 450 nanometers, okay, and the other axis is horizontal axis is the weeks of gestation. So if you plot this graph and this ODD, it will come into one of these categories, A, B, C. A is a lower category, which indicates either not affected babies or very, very mildly affected babies, where you can continue up to 38 weeks and then deliver these babies. So A babies are safe babies, okay, 0.01 to 0.05. Supposing the ODD falls between A and C, in between A and C, these are mildly affected babies. So if they are already nearing term, 34 weeks and so on, immediately deliver them. Supposing they are much preterm, okay, you start repeating the spectrophotometric analysis or MCA PCV and see how the baby is faring. Is it going into the C category or it is coming down into the A category? If it is coming down into the A category, then you can terminate at 37, 38 weeks. If it is going into the C category, then you have to do intrauterine transfusion. So this B category, you have to very carefully monitor these patients, babies. Then C category are severely affected babies. That means already they are hydrops. So these individuals, nothing can be done. If there is mild hydrops, then you can do a intrauterine transfusions, drag them at least up to 34 weeks and then deliver them. So most of them, the prognosis is very poor because they are usually severely affected fetuses. Followed, this is known as a Lilly's prediction chart. Followed all of you. So do an amniocentesis, draw an amount of fluid, measure the optical density deviation at 450 nanometers. So this deviation bulge, tip of this deviation bulge is measured and plotted against the gestational age and divide them into ABC categories. Okay, lowermost are safe babies, uppermost are severely affected babies. Middle way are they go either this way or this way. Depending on that, you have to manage them. That's what that table lo cheppindi. Zone 1, zone 2. Okay, zone 1 means lower zone. Continue the pregnancy and deliver. Zone 2 and 3, depending upon the lung maturity is present, deliver them. Absent maternal phenobarbital, of course, we are not doing any maternal phenobarbital nowadays. Okay, always cord has to be clamped. A quick cord clamping has to be done to prevent FMH, and then cord blood has to be collected for 5 to 6 tests. that is hemoglobin, ABO and RS typing, hematocrit, bilirubin, reticulocyte count, direct Coombs test, peripheral smear. So all these 6 to 7 tests have to be done on the cord blood. Only always leave the length of the cord long so that the baby may require an exchange transfusion. You can make use of the umbilical vein. So ఇదంతా చెప్పేసాను కదా నాన్న. If the woman is positive, then do husband's grouping. If the husband is negative, there's no need to worry at all. If the husband is positive, then test the woman and do an indirect Coombs test on the woman, see whether she is already immunized, right? Then forecast the likely affection of the baby, anticipate and formulate the line of management. Obstetric history has to be taken in detail. If she is a primigrada, there's no problem. And if it is a Paris lady, take a detailed history, any history of previous affected babies and so on, whether she has taken previous anti-D immunoglobulin was given or not, all those things. So indirect Coombs test has to be done to know whether she is negative or microbiology. The red Coombs test is done on umbilical cord blood, whereas indirect Coombs test is done on the mother. So the difference you have to note. Doppler ultrasound, now it is the mainstay of assessing the fetal anemia. So serial Doppler study of MCA PSV is a mainstay to assess the fetal anemia. So whenever the value is more than 1.5 MOM, it predicts moderate to severe fetal anemia. Right? So if you get this value between 24 to 35 weeks, that is preterm, and this is an indication for cardosynthesis and fetal transfusions. So now most of the centers have replaced the serial amniocentesis because it is an invasive investigation. Now we are not doing serial amniocentesis, but we are doing a serial MCA Doppler studies to detect the fetal anemia. So this is how you do a MCA PSV. So you have to look at the circle of Willis, locate the middle cerebral artery distal part, and then do the Doppler. So amniocentesis. So indications for amniocentesis are, I've already told you, whenever you are doing an indirect Coombs test, if the dilution is more than 1 in 8 titer, so you have to do an amniocentesis to know whether the baby is affected or not. Then previous history of severely affected baby. That is the most important factor which you have to note in the history. Right. Selection of time. If there is no history of previously affected baby, it can be done at 32 weeks and repeat it again after 1 month. If there is a positive history of a previously affected baby, then it has to be done 10 weeks prior to the previous stillbirth or hydrops. Okay, it has to be done 10 weeks prior. So this is the most important criteria. However, before 20 weeks, you cannot do amniocentesis because the amount of amniotic fluid is very less. So predictions have already done Lilly zones, low zone, mid zone, and then high zone. Fetal blood sampling, cord blood sampling. ఇది cardosynthesis. Cardosynthesis లో కూడా same thing అవే మళ్ళీ. ఎప్పుడు చేస్తామంటే only when MCA PSV is more than 1.5 moms to that gestation age. So blood group, hematocrit, direct Coombs test, reticulocyte, total bilirubin, hematocrit అవన్నీ చూడాలి. Okay, so intrapartum management, unimmunized mother, don't allow them to go for post-dated pregnancies. Always terminate at term. Then immunized mother, time of delivery depends upon the previous history of stillbirth, sudden rise in antibody titer. When ODD plotted on Lilly's chart is going up, then ultrasound Doppler changes. So mildly affected pregnancy, that is lower zone, can be continued up to 38 weeks. Severely affected pregnancies, if they are more than 34 weeks, then you can terminate pregnancy under antenatal corticosteroids. Supposing they are less than 34 weeks, then you have to do an intrauterine fetal transfusion till 34 weeks and then deliver them, right? So mode of delivery, unless it is preterm, very preterm baby, because the head will be large, C-section is preferred. Otherwise, C-section is only for obstetric indications, not for Rh negative per se. Do's and don'ts: careful fetal monitoring, gentle handling of the uterus, avoiding ergometrin or any other uterotonic, avoid manual removal of placenta, early cord clamping. 5 ml of blood should be collected, 2 ml oxalated for HB and peripheral smear, 3 ml clotted blood for ABO, RH typing, DCT, reticulocyte, serum bilirubin. So intrauterine fetal transfusions, when you do in moderately and severely affected babies, less than 34 weeks gestation. So the purpose of doing an intrauterine fetal transfusion is correcting the fetal anemia so that you will improve the cardiac function and hepatic function. So that can be done either intraperitoneal or intravascular directly through the umbilical vein. So freshly prepared O-negative packed cells with a hematocrit of 80 to 90%, they should be cross-matched with the mother. And then they are transfused into the fetal peritoneal cavity under ultrasound guidance at the rate of 5 to 10 ml per minute. Okay. So the volume of blood transfused depends on the gestational age minus 20 into 10. So you can start as early as 18 weeks and then repeat at an interval of 1 to 3 weeks till maturity. That is at least up to 34 weeks. That's the only way to salvage these fetuses. So not only intraperitoneal, nowadays it is more easier to do an intravascular transfusions. So this is done in fetuses with a hemoglobin deficit of 2 grams per deciliter or more from corresponding gestational age, or hematocrit is less than 30%. So here also you take O-negative packed cells with a hematocrit of 90% compatible with the mother's blood, and then transfuse it through the umbilical vein under ultrasound guidance. Again, it has to be repeated every 2 weeks until the hematocrit improves to 50%. Right? The procedure-related perinatal loss is around 7%, and antenatal corticosteroids to enhance pulmonary maturity. Okay. So all RH negative unsensitized women should receive 50 mics within 72 hours of induced abortions, spontaneous abortions, ectopic pregnancies, CVS in the first trimester. Beyond 12 weeks, 300 mics. Other therapies are plasmapheresis, intravenous immunoglobulin, donor insemination for supposing the woman is losing every pregnancy due to hydrops. Every baby is lost, then you can think of a donor insemination with an RH negative donor semen. And pre-genetic diagnosis, you can also think of surrogacy. So exchange transfusion is actually not our topic, it's a neonatal topic where exchange transfusion is life-saving procedure for severely affected newborn. All right, so that you can reduce the incidence of kernicterus. Here also you use so indications for exchange transfusion are RH positive babies with direct POMS test positive and cord bilirubin is more than 4 milligram percent and hemoglobin is less than 11 gram percent, right? And another indication is when the rate of rise of bilirubin is more than 1 milligram percent per hour despite phototherapy, and when the total bilirubin level is reaching 20 milligrams per deciliter to prevent kernicterus. So these are the indications for exchange transfusion, right? What are the objectives of exchange transfer? To stop hemolysis and bilirubin production, correct anemia, improve congestive cardiac failure, remove circulatory antibodies, remove sensitized RBCs, eliminate the circulatory bilirubin to stop hemolysis and bilirubin production. Repeated. So 5 objectives in this. To stop hemolysis and bilirubin, okay? To correct anemia, improve congestive cardiac failure, remove circulating antibodies, remove sensitized RBCs, eliminate the circulating bilirubin which is already produced. Okay, ఇదంతా అక్కర్లేదులేమోరా మీకు. How to do exchange transfusion వాళ్ళు చెప్తారు. Okay, సరేనా? Procedure they will tell you. Okay, yeah, okay then. Chemotherapy, phototherapy అన్ని వాళ్ళు చెప్తారులే. Thank you. Bye, all of you, all the best.
Thank
See
you,
you
ma'am.
again. Thank you, Nana.